Teacher Masahiro Nakazono. That's what he looked like at the time that I trained with him. I was 19 when I went to his school in Santa Fe, New Mexico. And he was an Aikido teacher. He was trained in Japanese bone setting, and he was one of the first generation macrobiotic teachers. He had trained in Japanese bone setting, manual therapy, and acupuncture and moxibustion before World War II, as a teenager also. And then he was drafted into the Japanese Army and fought as a soldier in World War II in the Japanese Army. And then came back from Japan, suffering from pretty extreme post-traumatic stress, and went to Nagasaki to treat people there after the bomb. And the conditions there were such that, you know, they didn't have much of anything. The infrastructure was gone. So largely treating people with his bare hands and with kind of traditional food remedies and stuff like that. And one of the things that he told us when I was training with him was that he wanted us to learn manual therapy to start with. We spent our whole first year of training with him learning the manual therapy. And part of what he said about that, I think I mentioned to you guys the other day, was that he thought some of us might find ourselves in a situation where it would be a luxury for us to have an acupuncture needle, so we better know how to help people just with our hands, even though we were going to be studying acupuncture and stuff like that too. So that was kind of one of my early lessons about like the seriousness of what he was trying to teach us.
Wasn't that when Reiki came out too? Was when the bomb?
And there's a whole story about that.
Yeah.
Actually, because the people, when Reiki came out, my understanding of the Reiki story is that around the time of World War II, there were some Japanese military officers who trained with an older Japanese man who taught them part of what he knew, and they called it Reiki. Come on over there.
We're just going to move this seat over here so we have a vacuum for our backs.
Ah, okay. Well, let's take a break. Anyway, so there was a guy that was a generation or two older than him, that they say was the person who taught the people who founded Reiki. And I believe that same person taught one of his teachers also, but it wasn't what came to me through that lineage wasn't Reiki.
Yeah.
But it had some similar principles.
Yeah.
So anyways, I was trained by him and his son in his school in New Mexico. Him and his son and some of their senior students. And a part of the manual therapy that we learned was the Japanese bone setting. So all this skeletal adjustments and stuff like that. And then I found this on my phone the other night, which was, I was a little surprised to see this, because I had forgotten that somebody had just sent it to me the other day. But this was a picture of my Cherokee teacher named Chief Two Trees. And he was a bone setter from the Appalachian medicine tradition, and he said Cherokee tradition.
One on the left or the right?
The one on the right, the older one. And this is my friend Malcolm that went to visit him after I had talked about him for years. Malcolm called me one time. He was like, "Hey, guess where I am?" So they took this picture, and I met him in must have been 1985 when I started my first acupuncture practice in Charlotte, North Carolina. And he was practicing up in outside of Asheville, North Carolina. And he just had a little house in the woods, a little cabin with a porch around two sides of it. And somebody heard about him, and we went up to visit, and he had people lined up all along the porch and sitting in their cars waiting and everything. And I was 22 maybe. And then we all introduced ourselves, and I said, "Hi, Matt, I do acupuncture down in, Charlotte." And he said, "Really? You do acupuncture? See if you can help that guy over there." And so I just started kind of working and doing things. That guy liked what I did, and so then he had me do somebody else, and then I got into this habit of going, I'd work in my practice 4 days a week, and 1 day a week I would go up to his house and spend the day just treating people and being around, listening to him and watching what he's doing and learning stuff. And when I was training with him, I already had background in visceral massage and skeletal alignments and stuff like that. And I would occasionally see him do stuff that I hadn't seen before. And sometimes he'd be like, "Hey, come here, I want to show you something." Or sometimes I'd see him do something and I'd be like, "Hey, how do you do that?" And he'd come over, or he'd have me put my hands on people, and then he'd put his hands over my hand and do things right through my hands. And so he'd be like, feel with this finger right here, or feel with this, and notice how this moves, and then boom. So I got a lot of really extra level training from him after I had already graduated from the acupuncture school from my Japanese teacher. And when I got to him, I was super surprised to see that his strategy was pretty much the same as my Japanese teacher. So they both would start in the abdomen, try to organize the organs, and then kind of go through the myofascial system, and then adjust the skeleton. And that was when I first saw that, I was like, wow, that's from two such different places and even generations, that their traditional thing was very much the same. And so I got to have a lot of, I almost felt like I did a residency or something with him. He couldn't teach me about acupuncture, but he definitely taught me a whole new level of how to use my hands and, doing skeletal stuff and more specificity about the organs and stuff like that.
Why do you do the bones after you do the, what's it
The
called?
myofascial
The
part?
myofascial, yeah.
Partly because sometimes there's, if there's muscles that are injured or shortened or
And you can't release the bones.
yeah, it makes it harder to release the bones, or if you do release the bones without addressing the myofascial part, then it just makes it go back.
Yeah.
Because it doesn't really loosen it enough to re-educate it.
Yeah.
Part of the idea is to release and lengthen the muscles and the connective tissue and separate any kind of adhesions and stuff.
Yeah.
So that the bones are able to move more, and then you adjust the bones back where they go. And then that whole process helps your nervous system kind of reset.
Yeah.
Part of what you've had experience with our treatments is within that sequence, things change and then they don't necessarily go back right away.
Yeah.
it's not like, sometimes you do have to do consistent treatment on things, but sometimes not so much. Anyways, I was super happy to see that picture of him the other day. I was like, oh, he's coming back. He wants to talk. Or he wants me to talk.
How interesting from those two sets, like the Japanese and the Cherokee, how the similarities.
Yeah. And actually, many years later, I met a guy through a friend. I met him in Seattle, and he was a guy that lived in Japan, but that grew up in West Virginia. And he was passing through Seattle, and my friend wanted us to meet. And he started interviewing me about Chief and about like, what did he do and what was his place like, and you know, I told him he had like a big plastic mayonnaise jar on the railing of the porch that was just like a donations, you know, because he didn't really charge. It was just like if you could afford to put something in. And kind of described the whole scene, and he said, you know, I can totally picture that because I recognize the type. I know the type. And I thought, there's a type? I didn't know there was a type, like he was a type. Because I never saw anything like that before. In terms of the way he practiced and the way it felt at his clinic, you know? And this guy said, yeah, I grew up in West Virginia and my grandfather was a guy like that. And he gave me a whole history of like Appalachian folk medicine and how it evolved and what things were kind of the elements of it, of the Europeans and the natives, and the, you know, the development of it as an isolated part of the country that didn't have other medical people coming in, and it didn't have, you know, even other people didn't leave and get educated and come back. It's like it was all kind of this isolated area. Anyway, so all those practices were cultivated in that. And he said they had two kinds of practitioners, the bone setters and the root doctors, they called them, which were like the herbalists. So Two Trees was both of those. But I've never really been an herbal guy, so I never learned that, but I definitely learned the manual stuff. But anyway, so those were my two like traditional bone setter teachers. And then that's definitely a part of what makes my treatments different. Even if I don't wind up doing the actual skeletal alignment part with people, I'm sure it affected the way that I use my hands and the way that I think about people's bodies and the way that I explore people's bodies diagnostically, kind of, is that I come from those kind of traditions. And particularly in Asian medicine, the bone setting traditions are affiliated with the martial arts traditions. So like through my Japanese teacher, that kind of tradition that came down to us for a while used to be called judo bone setting, and now they call it judo therapy. But it came from the same like martial arts tradition that led to judo and aikido and even translated over to Korea as like another martial art that I trained in, Hwarang-do and Hapkido and other stuff. So there's a lot of, when I was trained with Nakazono, he used to like say martial arts and medicine is the same thing. So, you know, like the principles you learn and the way you learn to use yourself you're cultivating both at the same time. So when I teach, and like some of the stuff that I'm going to talk about as we go here, are principles extracted from the martial art and what does that mean? Like, how do you use yourself in those ways, and how do you learn to do it, and how do you learn to think about it, even if you're not necessarily going to be a practicing martial artist. But there's principles that come out of there that you can still learn. Anyhow, so, and we should probably move into that.
At the window of your car is down.
Oh, right, it might start raining, huh?
Yeah.
It's
One palm on the front.
Yeah, this is just to stabilize everything.
You said your one forehead on the front.
Oh, well, on the back here is I'm feeling for the prominence of those sutures. So I want to see, how does that suture feel? Mm-hmm. And if this bone is more prominent and this one is more depressed, then that tells me probably something like that happened. So when I... Mm-hmm. So like right here, you can feel that suture. But it's better if you find it by feeling with your whole hand and fingers, and then walk your way towards it with your fingertips. Feel it?
Yeah.
Mm-hmm. So there's the wave that goes through the bones and the joints and the connector.
Yeah. I've been waiting for that.
Mm-hmm. And you see that? Pulling. Take a deep breath.
Ooh.
Keep your feet straight. Just relax. And let your shoulders relax. Take a deep breath. Deep breath in. A lot of what I'm doing here is like doing all these rhythms to feel how is she going to relax. Deep breath again. Turn to this side. Yeah, a lot of these. You know what I'm talking about?
Yeah.
The D channel. And then the first bladder line is what Dr. Roman called the second bladder line. And the second bladder line is along the shoulder blades.
Okay.
So, but I think of it as basically 3 bladder lines. So the biggest groove right next to the spine, along here, and then along the scapula.
Okay.
And these 3 lines basically go parallel all the way down, like that. So I'm going to follow those 3 lines, and I can do, I just did a lot of like sliding like this, where I would slide a little bit and then pick up behind where I started, slide again. So I get a lot of repetition. And I'm basically just trying to open, like I'm trying to take this muscle closest to the spine and kind of separate it from the spine, like stretch it and open up the space there. So there's a couple different ways to do that. The one that I most commonly do, especially if it's a smaller person, is I use my thumbs. And I make sure again that my thumbs are lined up in the direction that I want to exert my force. Like that. So I would do one when you get all the way to the sacrum here, to the end of the sacrum. It's kind of nice to do a slide across the hip rotators here. So
You're right above the bone.
now her hip bone is right here. So I actually go down the sacrum and then under that bone. As a guide to give me sensitivity. So I follow my other hand down like this. In case I go too hard or hit a sensitive spot and she reacts, I want to have a really sensitive
Okay.
hand there to tell me not to overdo it. So is it okay if I pull these down a little, Michael?
Yeah, of course.
Do that there.
This is called what do they call it? Fromage?
Effleurage?
Effleurage.
Yeah. This, to me, I just think of it as
We were
like
trying to remember the name of it last time.
putting the oil on. That's what I think of it as.
He's like, it's called feathering. I was like, oh, that's...
Anyway, so once I get kind of covered everything, I'll pull the arm down to get these muscles extended a little bit. And then I do, again, I'm reinforcing with my top hand so that I can keep the hand that's touching him as relaxed as possible. But then from here, I'm going to start from the space between the acromion, the collarbone, and the scapular spine. What do they call that?
Clavicle?
This is the clavicle, this is the acromion.
Oh yeah, the chromia right there.
Yeah. So I find this little notch in here, and from there, I'm just going to do a couple of lines. There's one that goes kind of along the front side of the trapezius. That's the large intestine. And from this position, I'm actually just pulling. So I'm getting the pressure by pulling here and then sliding along the channel. And then...
And where are you ending up? Are you ending up at the points like under his skull, or like where's your fingers stopping?
The neck.
Yeah, with the large intestine, I go up basically to about large intestine 17, which is kind of the side of the neck here.
Okay.
Or that's maybe large intestine 18. Anyways, it's in the side of the neck. And then the gallbladder one, I come along the gallbladder channel, which is kind of the top ridge of the trapezius. And I'll take that one all the way up to gallbladder 20. So I'll find these for you and kind of show you how to feel each one of them. And then I'll come over here and put some focus on the levator scapula, where it joins the scapula. Like that. And he's really muscular, so, and part of the thing here is there's layers of muscle. There's the trapezius, and then underneath is the levator scap, and then there's all these other muscles that are kind of layered. So you kind of will find yourself bumping over muscles as you go along these ones. But anyway, so I'll just do 2 or 3 lines of that. 1, 2, 3. I don't really pay that much attention to the back of the neck now because I'm going to do it a lot more extensively when he's face up.
Okay.
So then I'll come over to I'm going to do the 3 lines of the bladder. And depending on who I'm doing, I might do this kind of a sweeping technique that I was talking about earlier. Come down to the sacrum here and then off kind of along these ones and do a little cross fiber of the hip rotators. And I might do that a couple of times. And the body mechanics with these ones are, I do it differently. I try to apply the principles of the body mechanics, but I don't really have a specific technique. Like I wouldn't say like, oh, you have to do it this way all the time. Because depending, again, like I like this one, but my hands are strong and my thumbs are strong. So I can even do this on pretty big, dense people. But it takes a while to build up your strength to do that. So, so you may want to do that more on smaller people. Like you can practice on each other because it's not going to be that difficult. But if it was somebody much bigger, again, I might use my elbow like this, and I use my other hand in front of it to kind of give me a guide. But notice that I get my weight on top of my elbow. And again, I'm moving my whole dantian as I go. So my whole body is moving so that I can keep my kind of control of my weight on that one. And if I feel him start to tense up like that, I know I'm either going too hard or hitting something sensitive.
He's kind of sensitive. Wow.
So,
Yeah, you don't need that much pressure.
A little bit like that.
Huh?
A little bit. Does it last a little bit right there?
Right there.
Yeah.
Yeah.
The lower back is tighter.
So I'm giving you kind of a couple of different examples of body mechanics, but I'm actually applying my body mechanics principles of pushing with the bones, pulling with the muscles, and trying to keep the part that I'm making contact with him with as soft as possible so that I can be as sensitive as possible. But here again, I'm going down 3 lines. And he's got a lot going on this third line here. So, depending, I might decide to spend more time on this part up here. But anyways. Sometimes I like to intersperse the channel thing with occasional rocking of the whole skeleton just to kind of integrate things. And then I might do a little bit through this part, which is basically going to be the small intestine channel. But to finish that up, then I come to the other side. Again, depending on what I'm dealing with, I don't like to do a whole lot with the neck from here. I feel like I have much more control when they're face up. Anyway, so then back to the first line. And again, depending on whether I turn my hand down or up, it's going to change the shape of that part of my elbow that's touching him. So this second line to me, the first line is right next to the spine and the groove is obvious. It's like the spleen channel on the lower leg. Mm-hmm. The next one is halfway between the spine and the third one. And that one turns out on many people to be kind of like either right through the belly of that muscle or just to the inside of that muscle, like I'm almost stretching that muscle a little bit away from the spine as I go down. And then the third line here, there's a lot of conflicting layers happening here as well. There's like part of the lower trapezius comes down this way. There's rhomboids that go across this way. And then there's all the intercostal muscles. But this line is getting away from the spine and kind of more about the shoulder. And then again, as you get down below the shoulder blade, there's not a whole lot. You're kind of on the outside ridge of that muscle. And then I'll just do a little bit on the shoulder blade so it feels like I've done kind of a complete back. And then
Voila.
voila. Here, my actual stomach hurts. My stomach hurts down here. My stomach hurts over here. My stomach hurts down here.
Yeah.
It doesn't really mean anything when they say it. So I like this example of like, how do you break up the abdomen into quadrants and sections so that you can have a little bit more of an idea of where things go, or how the organs fit together. Anatomy books, when you look up abdominal anatomy. So if you want to start doing belly massage, you'll see a lot of this kind of thing. And one thing about this is that it's a male abdomen, so there's no female reproductive organs in here. And that makes a big difference if a lot of your clients are women like mine are. But this will give you a rough idea of kind of in an idealized body, where are things. So it's true that the liver is up in the upper right quadrant and that it does cross over the center line. Usually there's a little bit of it in the left side. It's true that the stomach is in the left upper quadrant. What you can't see here, because of the limitations of a two-dimensional drawing, is that the large intestine, the transverse colon part of the large intestine, in this picture actually has to be put with it looks like a bunch of grapes or something like that. That's actually an organ called the omentum. And most of the time, it covers up all of the other organs. But one thing that's really important and relevant to me is that when a person's laying face up, their large intestine is roughly like this. So the large the large intestine really starts in the lower right quadrant. And it starts where the small intestine inserts into the large intestine. And so the lower part of the large intestine is called the cecum. And then there's the ascending colon. And then this part is called the hepatic flexure. The hepatic means associated with the liver, and the liver is right here, this gray thing. So this is called the hepatic flexure. This is the transverse colon. This is called the splenic flexure. And then this is the descending colon. And then this is called the sigmoid colon, where it curves here, and the rectum. So it's important to know what's happening roughly in these different parts. And normally you have a really good visual idea of what you're trying to do when you get in there. So when I start, I usually start, we'll put some oil on the belly, and then I'll do a little bit of pressing in here and a little bit pressing up here, and just kind of getting a sense. And then I'll reach around, and with the same rock climber's grip, I want to get this side of the intestine. So I'm gonna try to move things through, because things can get stuck in different places in here. But for example, because the general movement of stuff through the intestines is in this direction, if there's anything stuck here or here or here or here, it's going to have to move in this direction. And if there's also something stuck over here, it's not going to have any place to go. So my general strategy with the large intestine is to start with the descending colon and get it to empty out from here and at least move to where it's ready to get eliminated, so that there's empty space here.
And you can tell when it's...
You can cultivate your sensitivity to where you will be able to feel changes as things move.
And you're feeling for adhesions.
Yeah, we'll get to that. First I want to finish the large intestine, because this one's pretty opiate kind of based pain medicines. Restrict the nerve signals getting to here, and they literally can't contract. They get really weak, so they're like.
That's why they also prescribe some sort of
Laxative.
That's why people get constipated on opioid medication or anesthesia or different things like that. But
How do the laxatives work? They put more
they
water
don't.
in the system, or they don't?
I mean,
they make the muscles
just
move, or how
adds
are they supposed to
fluid.
work? They add more water.
Well, there's two or three different kinds. One is called a stool softener, which is supposed to somehow infuse, you take it orally, so it comes in and has to work its way through the whole system. Sometimes they use castor oil for that. But the idea is that you want something that's going to get all the way to the end of the system and soften the stool, moisten it again. Sometimes they do rectally, suppositories of something like that will soften everything. Another approach that they use is a lot of laxatives are irritants. So you take them inside, and it literally is irritates your intestinal lining. Things like psyllium husks and stuff like that. It's scratches you and it's irritating, and so your body wants to get rid of it. So it stimulates everything to go get that out of here. But if you're taking these opiate medications, you can't do that. So if you take those kind of laxatives, all those irritants sit inside there irritating you, but you can't get rid of them. The other thing, since we're talking about it, so with another reason that people get constipated with opiates is also related to the fact that it depresses the nervous signal to the intestines, so they lose their muscle tone. And so one thing that happens, the reason I twist this sheet like this to show you, there it is, to make a point. Because in your intestine, there is this kind of squeeze, 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 squeeze. Even though when you look at this, it looks like there's a, you know, a line like maybe they're symmetrical, but this is really a, most of what's in here is either liquid or a very, like a thick liquid, like a smoothie kind of consistency. So, and when liquids are moving like that, just like from that section of sensitive chaos, they move in a spiral. So when your organs are trying to get them to go through, they're kind of helping to spiral them through. And because of the shape of it, especially at this corner, when you lose all of your muscle tone, this can go like that. Because like the way this part is connected with ligaments and stuff, but when it gets, you know, it loses all of its muscle tone, and food still is coming through here.
Hernia?
No, it's a bowel obstruction, but you could call it like a torsion, something like that. But it's actually really common, and you can fix it with your hands. It's really easy to fix, but anyway, so very often I find like post-surgically, sometimes post-car accident, sometimes with people that have taken either that are addicted to opiates or that have been taking long-term pain medication for various different reasons. You'll actually, that will kind of collapse, and then anything that's trying to move along will get to here and not be able to pass there. And then this part will get really empty, and maybe this part will empty out until maybe some liquids or some really liquidy poops can come out, but they get this thing that's very full, and it obstructs, and the longer it goes on, the farther back it obstructs, sometimes through their intestines. We had a friend actually that, I think you met Madonna, was an old friend of Stephen's.
Okay.
Anyway, she died from this, and she was, at the end, she was throwing up poop.
Oh.
Because she had shingles and they were giving her opiates for the pain of the shingles. But she had this and nobody knew about it, and so she never had a bowel movement, and then she lost her appetite, and then she was getting stomach aches, and then she was...
That's so sad.
It happens a lot. Actually, a lot of people die from this.
And pretty young too. Like, it's actually not some. You need to be an old person.
You don't have to be old. Because of the medication thing, because of the surgical thing. Anyways, I didn't intend to go into that yet this early in the class, but since we're here, it does happen. And you literally, with your hands, can go underneath, kind of find this, come from the top, find this, and you can literally like untwist it. And then suddenly things go bloop, and then all this goes bloop. Pretty soon they have a huge bowel movement and they're back to normal. And I actually figured this out when I was treating my teacher, Chief Two Trees, because he came back from the hospital and he had this condition after he'd been diagnosed with cancer, and he had a lot of pain medications. And by the time I saw him, he was like a couple days back from the hospital, and he hadn't had a bowel movement in a week. And he's the one that taught me a lot of this abdominal stuff. And I was working on him, and I could literally, he had lost so much weight, he was really skinny, but I could literally, like, from the side, pinch this part and, like, move it back and forth like this, and feel that it was empty, because I could feel the intestine moving back and forth against itself. So
Isn't
it was,
that under the ribcage, or are you feeling it here?
it's over here. It's in, in between here
Okay.
and here. So I could literally like feel it was empty, 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 and like a big tube of solid. And so, and I didn't have this picture in my head or didn't have the idea of this, but I was like, I could literally feel that it was twisted like that. And so I worked on it a little and like got that to go. And like pretty amazing. And then actually I felt it unblock and I felt this part fill up and I felt this part get soft again. And then about 2 hours later, he had like massive explosive kind of bowel movement, but cleaned everything out, and then he lived like another 9 months after that. But he could have easily died within a day or two from that. But anyway, so that was, I literally discovered this by having to do it on him. So I've never heard anybody else talk about it. But it's something that I see a pretty fair amount in other different contexts.
How high up does the top of your intestine go? Is it like the bottom of your rib cages?
Yeah, it usually is. But I'm going to talk about that too
Okay.
in a sec. But that's a good, very good question. Anyways, I got on a little roll about that. I kind of have an
There's a
emotional
reason for it,
connection
I'm
about
sure.
that
I
because
know
of
people
that. But
are on.
what's that?
Yeah.
There's a reason for it, I'm sure. I know a lot of people on opiates. A lot.
Oh, wow.
Do.
The other thing, speaking of that, since we're on the topic, one time that happened was I had a friend, David Coffin. I don't know if you remember him either, maybe hearing about him. But he had done like, I don't know, a 20 or 30 day juice fast. So he was like completely cleaned out and empty inside. And then to break his fast, he decided to like eat a couple pizzas and eat a bunch of chocolate and some other like maybe some pasta and stuff like that. So like from having a completely empty digestive system, he had this huge mass trying to make its way through all the little things. And it finally got here and it like pushed it closed almost, like just like, and then it couldn't get any farther than that. And then he was in severe, severe pain at one of the men's groups at Stevens. And I wasn't able to work on him, but there was another guy there because I was busy in the middle of some other emergencies. But I kind of on the fly explained to this other body worker guy what to do with this. And the same thing, within like 15 minutes, everything came out and he was perfectly back to normal again. So that's another way that it happens. Another example is, like I used to live in Seattle for a long time, and in Seattle it's like rainy and cold and miserable for months at a time, and then in the springtime, sometimes around Easter, sometimes as late as like 4th of July, will be like the first sunny day, and there'll be a holiday and everybody has parties, and everybody has, you know, and sometimes they'll have like a big barbecue. People that haven't been normally eating like this will go out and eat a bunch of ribs or hot dogs or hamburgers, drink a bunch of beer in the hot sun, and they'll get dehydrated, and the same thing, they'll have this big mass of food that they're not used to digesting that's kind of like trying to make its way, and suddenly it'll get to there and stop.
A lot of people that travel to.
I think that may be. It's
Hydrate,
really a common
yeah.
That
problem.
placement is also the ear. There's a bit, you know, as the intestines are all points in the body as well, right?
Mm-hmm.
So that's like the inner ear, and so they say, like, I don't know, one of my teachers said, like, if a child comes in with consistent inner ear stuff, it's usually they're getting stuck right there.
Oh, really?
Yeah, their food's being processed food or whatever.
It's really interesting.
Yeah.
We were all just talking about earaches too, like at the
Yeah.
beginning.
Start from this side, and I do like pulling to start to get the descending colon to loosen, and then I'll come around from here all the way up. Sometimes I'll get this part while I'm here like this. Come up here and start trying to mobilize things. And I often will do a few different circles. But the main thrust of the first 1 or 2 circles, or possibly more, is to feel what's going on with the large intestine. Get all of these curves smoothed out. Make sure this one's good. Make sure everything can move through here. And then the other part of that is that once all of this gets kind of softened, then you can actually pull this down a little bit, and then you can get into the liver or the stomach. So then when I get here, because this often in the beginning will be tight or full and not very movable, but after you go around and actually work things and soften them and get them to relax and get things to move through, you can literally move it out of the way. Then I can get up and start doing stuff in the liver. Yeah. And there is a section in here too in the abdominal part about a hiatal hernia, which we'll talk about a little later. But a hiatal hernia is when the stomach actually goes up above the diaphragm and into the space where your heart and your lungs are in your thoracic cavity. A bunch of reasons, we'll talk about that. But if that's happening, then once you get the large intestine out of the way...
Does that mean it puts like a hole in your diaphragm? Or
No, there is an existing hole in your diaphragm. Because your esophagus comes down, so when you swallow, it goes through that hole into your stomach. But then sometimes your stomach will come up. Yeah, happens also to a lot of people. But anyways, once you get the large intestine out of the way and any of that stuff sorted, then you can come in and you can literally like pull the stomach back down. So there's a way of actually like pulling it back into the abdominal cavity and pulling it out of the top. There's a whole bunch of things to say about that too. But anyway, so those are a couple of the things that I have in mind every time I start to feel somebody's belly, is I want to check, like, what's the condition of the large intestine? Is everything roughly in the position that it needs to be? How is this joint and how is this part of the large intestine? Is it full? Is it empty? How about this part? Is it full? Is it empty? Can I move it around? If it's full in the way that I was talking about earlier with like dry poop, sometimes this will be hard and dry and then it'll be empty up here. So sometimes I'm actually trying to like pull it backwards a little bit to let it pass more easily, to kind of break it up and let it pass more easily. Anyway, so I do large intestine first is my kind of main plan. And then I do the liver, then maybe the stomach, the spleen. The spleen is kind of too far in the back and too soft to really directly affect. It's rare that I would feel anything specific and go like, oh, that's a spleen right there. So anyways.
But sometimes it does fall, right?
Sometimes it ruptures and sometimes it falls. But I've never learned how to feel like, oh, that's a fallen spleen. But in general, you can get what they call in Chinese medicine prolapse, which means that everything kind of falls. Like, you can get a situation where everything's kind of like that.
What causes that?
In Chinese medicine, they would say a spleen deficiency. because one of the functions of the spleen is to keep the organs in their proper position. But part of what that means, the spleen is a big part of your responsible for digestion. So and also the spleen like is partly responsible for producing enough blood out of the food that you eat. So one thing that happens is if there's either a big shock to the spleen or a long-term like undernourishment, then things can start to collapse like that. Or sometimes if there's a big trauma, because of the opioid thing and the anesthetic thing also, sometimes if people have surgery or they take a lot of opiates and the muscle tone just gets bad, then everything also can collapse like that. Also, sometimes if there's a big shock, like somebody that you love dies in a car accident or something, and you're like, and then, so sometimes those big emotional shocks also can like, everything just goes, ugh, and anyway, so one thing that I often find myself doing also while I'm working with all this, if I feel like, oh wow, it's really empty up in here, like even maybe all above the navel, might be like hollow, empty, I can't really feel anything. But then lower down, like everything's just full and I can't tell the difference between anything down there. That's because everything's lost its muscle tone and it's all just sitting on top of everything else. But it doesn't even have sometimes enough muscle tone to, like I do a lot of vibration kind of stuff. And part of the reason is because like, if I can isolate and get a vibration to go into the large intestine, it will actually go like, just like we were saying the other day with the person's skeleton. You get a vibration going and you can feel it go through the part you're pushing, but you can also see it manifest on the toes and the head. It's like when I'm doing this, I'm looking to get a vibration to go and feel how it comes back to me. So sometimes by doing that, I can start to get a sense of like, what's the muscle quality of the organs, or how does how is that organ able to move? Is it able to move freely in the way it's supposed to? But it has to have muscle tone in order to do that.
The elasticity type of thing, huh?
Right. So if everything's like collapsed towards the bottom, and I'm like this, there's nothing to distinguish, like, oh, that's the small intestine, that's the uterus, that's the large intestine. It just sometimes feels like an undifferentiated mass. And then empty up here. So if that happens, then a lot of what I wind up doing is trying to push things back up. So a lot of my treatment, I'll actually be like pushing things back to try to get them to move back where they belong. And you can literally do that. It's often in one treatment if you really focus on it.
What about them stuck up? So you do that opposite?
Yeah, that's a lot less common. And usually if
gravity,
something is stuck up, it can be from the adhesions, like I was talking about in here. It can be the stomach that's stuck up, and that we'll go over that. There's a whole bunch of reasons why that might happen. The large intestine can be kind of like hard to get it to move down there, and there's partly for some of the reasons I talked about. But it's more common that things are collapsed. Happens a lot around birth or cesarean sections or heavy blood loss during birth or things like that. Sometimes if women have postpartum depression, this is a big part of it, and if you get their organs back where they belong, they'll like everything will change. In Chinese medicine, postpartum depression a lot of the time comes from blood deficiency, which is from the loss of blood. But it also comes from this kind of organ collapse where you're not able to digest your food well enough to produce enough blood to replace what you lost. So anyways, that's a big thing too.
Any question about when so when you're trying, if something is hard in here and you're trying to move it back up that way, could it injure or like cut the inside of the colon?
I've never seen
Like
that.
hemorrhoids, you know how when people have that coming out, could it somehow damage the inside because it's so hard and like,
I've never seen that. What does sometimes happen in this part, which can be associated with that kind of problem too, is diverticulosis, which is where people actually start growing like little pouches on here. And so those can actually fill up with shit, you know, and then they can get infected.
Yeah.
Then you have diverticulitis. Those can be pretty serious, but sometimes it'll be just a little nodule, and stuff will get stuck in there, and then just kind of stay there, and then it can be pain. It can get inflamed, but it's not really infected yet. So
are those things that you have to really ask about when?
yeah, like I had a long-term client who I suspected had that because every time he had like sharp pain in the exact same place in the lower left quadrant, and nothing I did seemed to change it. But sometimes it was better and sometimes it was worse. But when it was there, it was always in the same place. So I kept saying, like, I think you should get checked for that to see, because that's the only reason I can think that you would have that exact thing most of the time, but sometimes it's worse and sometimes it's better. And it doesn't seem to cause any other kind of problem.
And so when people have Crohn's disease or other something similar like that, ulcerative colitis or things, what kind of, would you just want to be more gentle during the abdomen massage, or what would you want to think about?
Yeah, that's a good question too. So, yeah, if it's ulcerative colitis, that means it's in the colon, which means the large intestine. So, I still do the same. And generally speaking, with all of the stuff I do, I try to stay below people's pain threshold. So if it's more sensitive, then I would go more light. But I don't think I have like a system for going like, okay, because they have ulcerative colitis, I'm gonna do something different. It's just I'm still gonna try to, you know, part of it is that they're, like if they have ulcerative colitis, they'll be like, you know. So part of it is to go in and literally like try to smooth everything out so at least whatever's stuck in there can pass through. And I often wind up like showing them where their dantian is and teaching them how to breathe into their abdomen, because a lot of the time they just breathe in their lungs. And if it's Crohn's, that's kind of the same thing, but in the small intestine more. And that also can be a lot of things twisted up in here. But here you can't really feel so much the direction. Like the colon is pretty obvious what direction it goes in, and pretty relatively easy to distinguish. But the small intestine, because it's all kind of tangled together, sometimes you can like identify a loop of it or something like that, but I wouldn't necessarily know if that loop is flowing this way or this way. Because maybe it's twisted or maybe it's, so I don't try to do anything directional in the small intestine the same way that I do with the large intestine. So in the small intestine, I do a lot of vibration kind of things. Or I would like find one place and pin it and then stretch away from it and maybe do a vibration with a stretch. And I try to go, like my strategy would be to go in and open up the spaces between things. Like that. And that's kind of just like we've been doing with the channels, is like going through and trying to open up the space between the structures. That's the same strategy that I have also in the abdomen. So even if you can't feel, maybe you can't tell the difference yet of the large intestine or the small intestine or whatever, you can still practice like finding a place where I feel something hard over here and I feel something hard over here. So if I just kind of like slowly work myself into the space, maybe do some vibration, maybe see if I can like push one side away from the other. Like what I wanted, my bottom line principle is like trying to make space for everything. So as your sensitivity gets better and better, and as you get to be able to distinguish different things from each other, then you'll be more effective at that. But even in the beginning, if all you do is go like, okay, well, I want to make sure that I pull this away from the pelvic floor. So I go in and I get all that stuff, and okay, and then I want to see if I can pull this away from the rib cage so I can feel at least a little space over the top of it before, below the ribs and above the, or if at least I can get in here and like make some space between those two hard balls, I feel. That's a good enough to start with. Some kind of picture like this. And it's like, this is a standard picture of what your uterus and ovaries are supposed to look like. And this woman, Heather, was like, so here we are, like this. But she pointed out that that's not really how it is. So like, if you look here, these ones do, the top one here does actually have an ovary. It's a little bit in the shadow there, but so what Heather was saying is that like if the person is laying on their back, then the uterus is kind of like curved towards the front like this, and the ovaries come around behind like this. So if I'm lying, so for example, in these pictures, you can see that's pretty much where that ovary is in the fallopian tube. So in your body, it's actually higher up, but it's not in the same kind of position.
Oh, yeah.
So, anyways, this is a much more realistic idea of where that is in your abdomen and where it is in relationship to the bladder. And let's see, in this lower one, you can see some of the things about what happens if you have adhesions that connect the uterus to something else. Like maybe your uterus is stuck to your intestines, or maybe it can get stuck to the abdominal wall, or maybe it can get stuck to the bladder. So then there's all these things that can happen with like somebody's menstrual cycle of, why do you get certain kinds of pain, or why do you get changes in your digestion or in your urination or different things like that. Why might you get bladder infection sometimes more frequently? Or anyways, a lot of it has to do with like the positioning of that and the mobility and where it's, you know, whether it's able to move the ways it's supposed to move and stuff like that. So part of what we'll be doing as we start working with each other is just keeping that in mind too, because when we start working on each other, you'll kind of get the sense it's actually pretty hard to touch them directly because they're in the pelvis and kind of protected by the pubic bone and stuff like that. So some bodies are different than others, and some it's more easy to identify and go like, oh, okay, that's what that is. Sometimes less. But they can also get, like the uterus is suspended, is connected to the abdominal wall by some ligaments. And so sometimes it can be where it's in there, sometimes it can be actually bent backwards, which is called retroflexed. Sometimes it can be pulled to one side or the other because the ligament's not loose enough to let it move the way it's supposed to. Anyway, there are all kinds of different things that can happen in that, which also you can address with working in the abdomen. So, anyways, I have no idea what time it is, but I think it's more stuff to my Japanese teacher. But like he worked with a lot of the poor people from the Appalachian Mountains, so you know he had a lot of clients that were really overweight or diabetic or like not very educated and stuff like that. And my Japanese teacher was like a very refined practitioner, and he was like he taught very similar to macrobiotic diet. So like his dietary principles were very strict, and he was like no sugar and nothing artificially processed and all those different things. And Two Trees used to do very similar manual therapy, but he also prescribed a lot of herbs for people. And so they would ask him questions, and he'd be like they'd ask him questions about how many times a day, or should they eat it, you know, take it before meals or after meals or whatever. And I had heard him tell people things like, you know, oh, just, you know, drink it, you know, take your herbs with your Coca-Cola in the morning or whatever. Like, and I was horrified. I was like, really? You don't tell him not to drink Coca-Cola to start with? He's like, nah, just take the herbs with him. And I realized eventually that it's like he had already given up that fight. Like nobody was gonna listen to him and not drink Coca-Cola. So he was working in a context where he just had to do the best that he could. But I was still in that stage with him where I wasn't sure if I really trusted him or if I really wanted to commit to like spending a lot of time with him. And one day I was at his house and we were seeing people, and this older woman that must have been in her 80s at least came to the house, and she was like literally like bent over like this, walking with a walking stick, and she could take little tiny steps like that, and she'd look up sideways to talk to you like that, and like she climbed up the stairs, and she lay down on the table.
She was able to lay down?
Well, they helped her get up on the table. I think they had to use a step and everything, but he used really low tables also. But they got her laying on her back on the table. And then Chief had this other guy there that was learning from him also, like a big burly guy with a big long beard and like farmer overalls. And he had that guy come, he was like, come on over and help me with this. He had that guy grab her by the ankles, like this, and he said, okay, when I tell you to, give a big yank on her ankles, like that. And then Chief grabbed her by the belly, like way down low, like this, and did what I just was showing you guys, but he like grabbed her skin, I'm not gonna do it anymore. he grabbed her skin and like picked her up, and then there was a lot of stretch in her belly, so, but he picked her hips off the table, and then he kind of like shook her, like he dropped her, but then he stopped her before she hit the table. So it was a pretty strong, extreme move. And before he did that, he was like, okay, when I tell you, and as he did that kind of thing, he had the guy like in coordination, like while that was happening, the guy gave a big yank on her feet. And she kind of went like, like, I was like, oh my God, what happened? And I was standing there like this, watching him do it and this guy, and I was like, I didn't know what I was about to see. But so as soon as that happened, I could literally see, like when she first showed up and she was walking like this, and you know, her face was like chalky white. And when he did this, I literally saw the color like go up like this into her face, and her face turned like red again. Not bright red, but like there was blood coming up into her face, and her eyes got all sparkly and shiny, and she got off the table and she was like, oh, I love it when you do that. I was like, holy crap, so I guess she comes here for that regularly, which I didn't know. I thought they had just met. But anyway, so I was like, oh, okay, so she knew what she was getting into. But then afterwards, he told me that was the way that he was doing like an adjustment to help to position her uterus that was retroflexed and maybe twisted. So, anyways, that was the first and only time that I ever saw anybody do anything like that. But so this whole thing that we just went through is something that I evolved out of that experience. It's of course a lot gentler way of doing it. You don't need an assistant. Really helpful for women, any kind of menstrual cramps or other kinds of issues. It can be.
So you feel like it repositions the uterus?
It can. And I do it by stretching and then shaking it while it's stretched. Not that with the dramatic movement like he did, but but also, for example, I had a woman come to me one time she had some tearing, like when one of her kids was born, she had some tearing along the muscular part of the vaginal walls, but on the outside, not on the inside. So there was some tearing on the outside that left some kind of gaps in the musculature, and her bladder would collapse into it. And so she had years of having like incontinence where she couldn't hold her urine, and if she laughed or sneezed or something, then it would squeeze her bladder and she would be incontinent. But actually with 1 or 2 times of doing this, it literally like pulled the bladder out of that space, and that space was able to close back in again, and so it didn't go back in. So maybe 1 or 2 treatments with this woman, and she didn't have that problem for like 3 years. Eventually it started coming back a little bit, but it was pretty dramatic. So it's one of the kind of things that I've seen happen with this. But also this woman that I keep talking about from Australia, she has been talking a lot about doing treatments to help reposition the uterus, and how she's actually written some pretty cool stuff about how common it is and what kind of problems come from that and stuff like that. So I don't know how she does it, but this is a way that addresses a similar problem.
What would you call a technique? The stomach pulling? Skin pulling?
That technique?
Yeah. Is there a name for it you'd use?
I never had a name for it.
Stomach stretching.
Yeah. like I said, I only saw it that one time.
Mm-hmm.
And I just kind of did it over time, like it evolved into what it is that I do now.
You could call it the takeaway, the grab and go.
Yeah, but I never had a knife. I don't know. I'm not a big
And where
gamer.
did you meet that teacher? He lived in such a remote area.
I met him at his house actually, because I was working. I thought this was a pretty cool one too. That's why I included it. There's this one where if people come in and they say, "Oh, my stomach hurts," that could mean anything.
Yeah, I mean, definitely like had it.
Yeah, you could feel that I had a good grip on it.
Mhm.
So were you on top of the stomach at that time?
Right here.
Yeah.
Yeah, that's something to spot.
We're gonna start from the beginning again. So pick up your foot and put it down. So is that, that's good there? All right, so pick up and start to extend your foot. And then you can give her a target to come up and touch. And then another target over here.
You let go of it.
Oh, sorry.
Oh, did you let go?
Oh, did I?
I don't feel
No. Oh, maybe I did. Okay. Actually. There it is, yeah.
Yeah.
Okay, maybe.
And then we're gonna go up to the next one. And test it
Yep.
to make sure. So you good
Yeah.
there?
Yeah, got it.
And let her come up to 90 degrees from her hip. And the same thing over here. Because it's the ending part is often the hardest. And then the next one.
I feel like we're not quite on it.
Yeah.
Like
Right now.
You're too into my stomach.
Or where I was.
So let's have you pick your foot up again and put it down. And pick up and put it down. Again and then. Alright, you keep your hand there. So she's gonna want to go there. Yeah. Okay.
I don't feel like a specific one, but there's lots of other things that are around him.
You feel it more now?
Yeah.
So that's what you want, is you have to press hard enough to feel, to be sure that you're pressing the specific part of the muscle you want to. And then I'll come up again. Same thing, Amanda, pick up and relax. Is that right there?
Yeah.
Oh. Okay. Yeah, this gets very intense, and this is a good time, so.
So by pushing on these, it's resetting them?
By
Or is this just
keeping the
feeling-
attention on there and letting her go through the motion, it's helping her reset.
Yeah. So that, is there another one?
There's going to be at least one more, maybe two, but I'll let you find them this time.
Straight.
Yeah.
So let's see if there's one more. Sometimes it goes up to the navel, sometimes it goes one higher. That's right there. Yeah? So there is one right there. And then there's right there. right. So, yeah, maybe we could have one of you other guys do the other side.
Yeah.
To the left. Rotate to the back. Rotate to the right. And back to the front. You feel how that movement translates to the muscle?
Mm-hmm.
Now I'm going to go down one more. I'll have you. Oh, wait a minute. What was I going to say? No, so I'm doing it. I'm getting a little ahead of myself from the demonstration. So I'll go back to the first point. So what I'm going to have you do is go through, do that circle 3 different times.
Super painful.
To the back. Right. Right, and then relax. And now I'm going to have you go in the opposite direction 3 times. Right. Okay. So, Amanda, I'll have you come around. So this one is a really different one. It's like the same muscle, but a whole different set of movements that's going to have to make. So, do the first circle again. So you're going to do 3 times in one direction and 3 times in the other direction. And then I'll have you put your knee under there so you feel the position. And then you're going to go down to the 3rd point on the iliaca.
How many points are there typically?
I typically do 3.
3.
Yeah.
And then when would you use this one instead of the other one? Or would you use
Actually,
this?
nerve and stimulation and stuff like that. And, but the vagus nerve is one of your cranial nerves. It comes down kind of parallel to your esophagus and passes through the same space, the esophageal hiatus. And then it branches, and it has branches that go to all of your major organs. So there's something about the vagus nerve and how it connects and coordinates, like your gut brain with your brain. You know, there's a lot of people talking now about like different ways that your abdominal environment plays into emotional stuff and intelligence in different ways. So if you get a hiatal hernia, it can also impact the vagus nerve, and sometimes in very unpredictable ways. So you can wind up having all kinds of different symptoms that you wouldn't necessarily associate with a hiatal hernia. In fact, most people don't. I was lucky when I was training with Chief Two Trees. There was a chiropractor in Asheville, North Carolina at the time. This was back in the 80s. And he had just written a book about it. And so he came over, and then he was the one who showed me, and Chief, I think, how to do this manipulation for the hiatal hernia. How to tell what it is, and how to feel how it's, you know, what it feels like when it's happening on somebody else, and then how to do the manipulation to drop it back down into the abdomen. And let's have, what are we going to use for this one? Can we use you? Alright. So, let's see. So normally when I do this, I do it partway through the whole process. Like I don't normally just go like, oh, lay down, I'm gonna go right to your stomach.
It's like the pill feels very normal.
So usually I'm gonna start with like a lot of the stuff that we did before because I want to get her organs relaxed. I want to get some sense of whether it might be happening, and if it is, what's the condition of the other organs. Like we were talking about the other day, sometimes there's this torsion that happens in the large intestine and blocks the passage of stuff through the intestines through here. And if that happens, sometimes the transverse colon here fills up, it gets really hard and not very mobile, and that can actually put pressure on the stomach as well. Anyway, so I'm gonna take a little time and get a sense of what's happening here.
So that could
Okay, word.
cause a hernia as well.
It can also do that, so sometimes you have to like untwist the intestine so that things can pass, so that the large intestine will be softer, so that you can move it and you can get behind it, stuff like that. And there recently was a person from our Colorado community that had, he actually, he had some bad alcohol problems and he wound up with a very severe hiatal hernia where something like 60% of his stomach was above his diaphragm.
Wow.
And it was so constricted by the muscle there, by the diaphragm, that it cut off the blood supply and that part of his stomach died. And so, I don't know why, for some reason they didn't diagnose it very early. And so by the time they figured out what was going on, it was in really bad shape. So they had to do surgery and cut out his stomach. And
If you went to a Western doctor and you just had a mild one, would they know how to push it back and be able to push it back, or what would they tell you?
they generally don't. As far as I can tell, they generally don't even look for it or talk
Yeah.
much about it, unless it's bad, like our friends.
Yeah.
Because normally, or even when I was kind of Googling it to see what to put in the book, a lot of what I read about Western interventions were about doing surgery.
Yeah.
And they don't do surgery unless it's pretty severe.
They would just wait.
So they would, I don't know, there's a whole thing around that where they, you go in and you say, oh, you have acid reflux. Okay, you have to take these antacids or all these pharmaceutical things to stop your stomach from producing acid or whatever.
Yeah.
And rather than just putting the stomach back where it belongs so that you don't even experience that problem.
Yeah.
So it seems like mostly pharmaceuticals and surgery are the
Yeah.
only thing they got for that. So, and I have seen other people on YouTube videos like demonstrating the essentially same technique. So it's more of an osteopathic thing or a chiropractor thing. So, anyways, I don't have to do too much other stuff around here, but I do want to do a little bit of preparation. Okay, so now I feel like, her transverse colon is here, and the stomach is going to be behind it. And now I can feel even after that little bit that things are soft enough. If I start over on this side, I can actually go in and start to feel the transverse colon is soft enough that I can start to push it down out of the way a little bit. And what I'm trying to do is make enough space that I can get a good grip on the stomach. And it doesn't have to be very strong movement. I'm just kind of gently pushing it out of the way. So now, the shape of her stomach, well, in general, again, your stomach can have lots of different shapes. But this is kind of the classic idealized one that they show. So the esophagus comes down and passes a little bit to the left, is where the esophageal hiatus is. And then there's this part of the stomach over on the farther to the left. That's called the fundus. So you can actually put your fingers in and grab the fundus of the stomach and pull it down this way. And you can kind of see from the diagram, basically you're going to try to gather the fundus of the stomach and go close, find a place where when you stretch on it, it will pull on the esophagus. And if they have a hiatal hernia and it goes down underneath, there's kind of a classic sound that it makes. It's like a squirting, gurgling sound. And we might hear that or might not. I don't know if it's happening with you right now, but anyway, so either I'll use 2 fingers like this, maybe, or these 2 fingers. And I go just to the left of the apex of the ribs, to the left of the center line. And I pull the skin back a little bit like this so that I don't want to go too close here and pull this skin over her ribs, because the elasticity of the skin will keep me from getting deep enough. So I kind of move the skin a little bit out of the way. So I have a little slack. And then we're going to start feeling in here and see, like I can already feel the top of the stomach here. This is part of what I was saying, or I have been saying over and over, like you find when you, like the principle is you press in and you want to feel an empty space under your fingertips and then some structure on one side and some structure on the other side. Like that's the basic way to try to develop sensitivity in your hands. And when I do that here, I'm trying to feel for the fundus of the stomach just on this side of my fingers. And if I can, then I can work my fingers into the space on top of it and get a better grip on it, like that. So it's approximately here. And I can feel, if I put a little stretch on it, that I can actually feel it already stretching up her esophagus. So take a deep breath. So I have them breathe so I can coordinate my movement with it. So I'm going to have you breathe in again. As she breathes out, I'm going to start stretching. So I'm putting pressure down in this direction and kind of scooping. Deep breath again. And deep breath again. So I don't necessarily think it's happening with her right now. But another thing that I sometimes do with people when I'm looking for this is I get them to stretch their esophagus away from. So part of the whole thing is that if I can lengthen that whole structure. Like if the esophagus stretches and elongates like that, it also gets thinner, just like a rubber band. So if I'm trying to pull everything down below, if I lengthen it this way, then it gets thinner and it's easier to slide it through there. And so in order to do that, what I have them do is like expand their chest this way and tilt their head back and look slightly to the right, almost like you're reaching with your chin to touch something. So like if I come in here and find the top of the stomach again and give a little stretch to the esophagus, and then I'll have you arch your chest and put your chin over a little like, yeah, you feel how that stretches it? Like when she goes into that position, I can feel the stretch come all the way down to here and relax. How did that feel?
Good.
It's pretty obvious, right? You can feel the connection all the way down.
Yeah.
Okay. Anyways, that's it. It's pretty simple. When we go around to work on each person, maybe we'll feel somebody might have one. And so we may be able to feel it move or hear it move or something like that.